Inflation is 1 billion plus. So you can imagine a product registered at that level, authorized at that level. It is free to move throughout Africa. So you can imagine the market, the economy. The other thing AMA will bring in is there are molecules like those you are saying, biosimilars, biotherapeutics, whatever name you call them, where the capacity in the continent is still low to evaluate. Now, because we'll be doing them jointly, then we'll be having the advantage of using the few experts that are available within the continent. And so instead of taking 5 years, 2 years, maybe 6 months, you can have the product in the market. Let me stop there first.
Yeah, thank you. But before I pass to a question to Dr. Sarah, I just wanted you to speak to this monster we've had mentioned all over called ML3, perhaps, and what does it mean to a manufacturer in Kenya?
Okay, ML3 is a WHO classification. There's from level 1, maturity level 1, to level 4. Though there's another one I call level 5. It is a bit silent. But the minimum that is required for any country so that it is acceptable by WHO that the product assessed by that authority and can be allowed to move like the WHO PQ is ML3. And that means the authority then, that is ML3, is stable enough and be able to be always reproducing the results. There's consistency in the production of results that it produces. In other words, the quality management systems of that organization are well known and is predictable. And there are 9 regulatory functions that are assessed. So if you are maturity level 1, it means you do some functions. It is not systematic. It's a lot of errors. Level 2 is more stable. Level 3 now is acceptable. Then if you go to level 4, it's higher. And then level 5 is what they call the world listed authorities, like the US FDA. So at that level, then you are what we call the stringent regulatory authorities. And that opens the big markets for you, like the markets in the US. Anywhere in the world, your products can be allowed to go.
Yeah, so, yeah. Thank you. So it sounds like a label. You know, even when you're buying clothes, we sometimes are tempted to buy certain labels. Dr. Sarah, speaking to quality, you know, could you tell us what gives you comfort from where you sit that the quality of the products that we get, you know, across, especially even maybe at the next door community pharmacy in our hospital, is good, and what we do, what you are doing to support the local manufacturers towards that end. Thanks.
Thank you. It's actually a privilege to be on this panel. First and foremost, let me begin by saying that the National Quality Control Lab is a WHO pre-qualified lab. We are also ISO 17025 accredited, so we have the global recognition. Actually, we were the first public lab to be WHO pre-qualified, and we are among the 57 labs worldwide to have the WHO pre-qualification, so it's not an easy thing to attain. Because of these two standards, what we do, because we are a government agency that tests health products and technologies, we are able to assure the public that anything that has gone through NQCL is of the right quality. So if you test your products with NQCL, because our mandate is to protect the Kenyan patient, or actually the Kenyan public, from substandard and falsified products. That's actually our role, because we're under the Ministry of Health. And therefore, if there is a certificate from NQCL, then in that case, the public will be assured that that product has met international standards. So that actually gives me the assurance. If I see a certificate with an NQCL stamp on it, then it's of the right quality. Thank you.
Is the testing affordable to our local manufacturers?
The testing really, the cost of testing is something that we are looking at, because as a government agency, we need to ensure that there is access to this service. At the moment, I think we've done a market survey, and we've noticed that we're actually comparable to other labs in the region. We would want to bring down the costs so that it's more accessible. We would want, if a Kenyan has any doubt on any product that they've probably procured from a pharmacy, they should walk in to NQCL and have it tested. We've actually had patients who have brought in maybe an insulin product, and they feel that their glucose levels were not managed, and they brought in, and of course, working together with the Pharmacy and Poisons Board, we were able to collect additional samples from the market. So to answer your question, we would want the prices to be a little bit lower so that we can, the Kenyan or the common mwananchi can walk in and have their products tested. But for the local manufacturers, we would also want to work even more closely by developing a curriculum so that we build or we share the expertise that we have gathered over the years, especially in the area of testing biologics. We are working very closely right now with the Kenya Biovacs so that by the time they start manufacturing, we want to be able to match their capacity so that we can test, or we can carry out the independent lot release testing. As you are aware, the vaccines are meant for a healthy population, so we do not want to have our Kenyans exposed to a vaccine that has not been tested and could potentially cause harm. So therefore, there's also the value add that we want, not just to be a testing lab. We want to build capacity with our local manufacturers and just have a pool of experts that can inform policy. Thank you.
Yeah, thank you. Maybe just a follow-up question that you need to shed light on. There are lots of products that we classify as health products, including devices. I think in this country we've had maybe even cases of certain products maybe that are used for warming up, having issues. So could you shed light on what you are covering in terms of the devices? There's a lot of talk now even in terms of having handheld devices for purposes of diagnostics. So what is our coverage so far, and what do we need to support the manufacturers also who are in that space beyond medicines? Thanks.
Thank you for that question. The area of medical devices is relatively new. Actually, I think the Pharmacy and Poisons Board now just recently, not recently, probably in the last 5 years, they started regulating the medical devices. And so NQCL has also started equipping our lab so that we can be able to test the really wide range of medical devices. Currently, we can test needles, the syringes, gloves, condoms, but we want to expand our scope so that we can test nebulizers, hearing aids, implants. There are so many medical devices out there, and they keep coming up. So in terms of even the classification, just getting to know what is a medical device so that we can get ready to test as they get into the market, and also expand into the post-market surveillance exercises. Because if Pharmacy and Poisons Board carries out the post-market surveillance, it needs to be sure that by the time the product comes to NQCL, we can test the products and assure the public that we don't have any falsified or substandard medical devices in the market. Thank you.
Yeah, thank you. I'll be coming back to you to share insights on how you link with the other labs, because we hear there are quite a number of labs. But before that, I get to Milka. Milka, development partners, are known, of course, to have the check. Yeah, and you're in that space. Of course, we have USAID, being one of the big donors in this space, in addition to other global agencies like, the Global Fund, Gavi, and the like. From where you sit, how do you see the landscape of local manufacturing based on the experience you've had, with the investments, especially in the strategic programs. Yeah. And you could speak to, how you are supporting exchange in terms of knowledge and technology transfer. Thanks.
Okay. Thank you so much. I think just to introduce, USAID is a development partner. I think you've rightly said that we've been supporting the Ministry of Health in a number of areas, including providing to improve access to essential health services. And I think most of it has been in the strategic programs that's supporting access to treatment for malaria, HIV, TB, and also essential health care, including access to reproductive, maternal, and newborn health, and also strengthening health systems across board, from supply chain, health financing, supporting strengthening human resources for health, among others. And I think when it comes to now supply chain or looking at local manufacturing, one of the things we've been doing in the recent past is also supporting the Pharmacy and Poisons Board. Our support has really been on technical support to improve their capacity to be able to meet, of course, what Dr. Sioi was talking about, majority level 3, and that has been a focus in the last several months. And I think the objective there is really to make Kenya to meet the global manufacturing regulatory standards, because we think that is an opportunity for the industry here and also for the region. And that is one thing that we've been doing in terms of providing technical support and also supporting them in looking at the policies and standards, and that's something that we've been working with the Ministry of Health. But in terms of what you've asked about how do we look at the landscape, I think you've rightly said we as a development partner, one of the things has been what can we do more to support the industry, and one of the things we've been looking at is our policies supportive also to be able to actually procure some of the essential products we are procuring locally. And I think that's something that we are looking at. I think we had the leaders summit that was there in the US last year in December, and I think the ambassador that leads the global health security and diplomacy made a commitment that by 2025 they will be buying about 2 million test kits from local manufacturers here in Africa, and by 2030 to ship about 2 million patients that are on HIV treatment to the products that are actually manufactured here in Africa. And that's really why we are committed and working with the Ministry of Health and also working with the regulator to be able to improve the standards, because we know for the market to be incentivized, then we need the regulator to be able to meet global manufacturing standards so that it can actually generate opportunities for even other investors to come and support the local manufacturing industry here. So that really has been our effort, and we are committed. We are here and working closely with the ministry, the government, and the Pharmacy and Poisons Board, among other key stakeholders. Thank you.
Yeah, thank you. And speaking to the bit on quality, I want to turn to Dr. Luciola. We've had technology transfer mentioned, I think, by almost everybody. Yeah. I think you sit at the heart of one of the core government initiatives that is expected to drive that agenda. What have we done about it, and how does the future look like in terms of tech transfer?
Thank you for your question. And just to start off with the quality aspect, Dr. Muteru mentioned how closely the National Quality Control Lab and Kenya Biovacs are working very closely together to ensure that the products that come out of Kenya Biovacs are of the highest quality, safe, and efficacious. So that is key at Kenya Biovacs. And as many of you know, vaccination, immunization, vaccines that are used for these campaigns, it's critical that they're of the highest quality and safety. So two things to touch on quality. One is through the manufacturing process. So at Biovacs, we are applying the GMP requirements, the good manufacturing practice requirements, as we set up the facility in preparation for the downstream manufacturing activities for the vaccines. So that's one aspect of quality which is really important. And for GMP, again, to mention, we are relying heavily with the the Pharmacy and Poisons Board working very closely to ensure that what we are putting together is compliant in terms of GMP. And then secondly, one of the targets that we are looking at is the WHO, the World Health Organization, pre-qualification mark of quality, which again Dr. Muteru mentioned about it. So WHO PQ is a very high standard, if you like, of quality of the product. So that's a target that at BioVax we aim to achieve as we move forward in this process.
We've had a lot of hype about messenger RNA vaccines. Yeah, I think it seems to be like the future of vaccine technology. Maybe looking into the future, what sort of roadmap do you have to bring those products to or have those products, produced locally? Thanks.
Thank you for the question, and maybe I can just touch on it on the response and possibly ask the expert who's sitting at the end of this panel, Dr. Kimotho, to comment from the Kenya Medical Research perspective. But from a manufacturing perspective, in terms of application of the mRNA technology platform, Kenya BioVax is already working very closely with the WHO mRNA Technology Transfer Program. This program is for Africa. This program is housed in South Africa, in Cape Town, at a facility called Afrigen. Now, in Africa, the WHO identified South Africa as the hub for this training program and recognized 6 countries across the continent through which the program could be applied. And Kenya was one of the identified countries, and the Kenya BioVax Institute was identified as the site where this program will be applied. So we are technology partners when it comes to mRNA technology. And then just before, maybe you can allow Dr. Kimotho to mention, there's huge potential within the mRNA platform in terms of applications across various therapeutic categories, not just vaccinations, immunizations. There's huge potential in oncology. There's huge potential even in the future when it comes to infectious diseases, neglected tropical diseases, huge potential to apply mRNA technology. The one that stands out is the agility and flexibility in the platform, how you can be able to start slow and scale up really fast in a very cost-effective manner. I think I'll stop there.
Before I get to Dr. Kim, when do we expect the first product from BioVax, even if it's form and fill?
Very soon. But then just to be a bit more specific, so we are looking at around 2026, 2025 to be able to roll out the first products from the fill and finish facility at Kenya BioVax, and starting with the childhood immunization program vaccines. Thank you.
Yeah, that addresses the essential ones. Dr. Kimotho, as you shed more light on tech transfer, I think when we were making introductions, there were quite a number of pharmacists here. Perhaps maybe you could shed some light also on the sort of multidisciplinary professionals that we need to get these things moving, and whether we actually have that capacity. Thanks.
Thank you so much, moderator. Before I can answer that question, allow me to talk about mRNA technology. I'm always passionate about it, given that, this is the technology of tomorrow, today. And looking at it, the landscape of the vaccines, especially for vaccines or production of these other biotherapeutics products, the future is mRNA technology. This technology, it can be personalized, individualized, and it is a technology that is very easy to adopt. And looking even the issue of mechanizations, you require a very small room, very tiny room for you to produce mRNA vaccine or mRNA product. And at KEMRI, right now we are working on production of mRNA for Shigella, malaria, and even chikungunya. And you are going to see, the landscape changing. You are going to see more of the vaccines being based on mRNA technology. And it is no wonder the Nobel Prize for this year is those scientists who developed mRNA technology, Drew Weissman and Carico. Now, coming to the issue of product development. Product development, it cannot be done by a single profession or discipline. It is normally a kind of, you do your work, you hand it over to the next person. A biological or biomedical scientist will do the basic research, and then then these scientists will be able to possibly come up with mRNA. But you require a pharmacist who will come and do formulation. From formulations, you have to pass this particular formulation to a clinical trial. A clinician has to come in, and so on and so forth. Pharmacokinetics, they must do the pharmacokinetics, of the drug. Therefore, drug development, it is a multidisciplinary affair. There is no single profession which can handle the issue of drug development, technology transfer alone. You also need business people, because everything that we do, it must make business sense, because it must be sustainable. Therefore, in summary again, we must involve all the professionals in technology transfer and even product development. Thank you.
Yeah, thank you. And speaking to the multidisciplinary professions that are required, I want to turn to Dr. Sioi as the regulator's voice. We have new regulatory framework underway, or legislation and the like. And of course, we have kept saying, I think in the past, and as you saw in Dr. Menge's presentation, that we have challenges also in capacity, capacity, human capacity or skills, So could you speak to how perhaps maybe in the future we are addressing these in terms of the, the gaps that we have in human capacity, and whether, you feel we are ready in terms of the professionals that we are preparing, because you also have a role in terms of licensing. Thanks.
Thank you, MC. I totally agree with what Kimoto said. It's a multidisciplinary team that does drug discovery, even regulation. Is not usually it must be a pharmacist only. There are areas the pharmacist will do. There are areas a toxicologist will be involved, a biomedical engineer. The engineers themselves, if you ask these guys in this room, how many project engineers they have when they are building their factories. The validations of equipment is not done by the pharmacists. It is the engineers. Replacing the HPLC lamps is an engineering. So what are we planning then? We have the short term. We discovered that in the country there are many people, though we don't know where they are. The universities churn out people, we have no inventory of who is where. So in the board, we decided that we needed to take inventory of the people that are required in industry with their qualifications and where they are. You may get good engineers in the University of Nairobi, get good business case people from Strathmore University, but all of them, they are within the country, but we don't know where they are. So we are trying to take an inventory of where these people are. Even as you said, laboratory services. There are various laboratories. You may find that the KBC lab is very good in one doing something. The primary research lab is very good in, yet they are not regulatory labs. So how do we harness these people, because they are within the country, to at least help us perform our functions? So in the short term we are doing that. The next level then is the training, the capacity building. There is short-term capacity building where Kinamilka Choge are assisting us for short courses. But then we are also sending people for master's degrees in particular areas as a long-term measure. It's very deliberate. And if I told you an example, at the pharmacy board now, there are 5 people doing their PhDs. Because at some level, for us to become very stringent, we require that the people who have PhDs are the ones who do their assessment. It is a science. Me, I don't have that. I am a regulator, but from the administrative part. They do the science, recommend, then I would announce and say, I'm giving it authority. You close because of, but the people who do the real work are scientists. So it is multi-purpose. And we have deliberate efforts to make sure these people are there in the short term, mid-term, and long term. We have reviewed curriculums with the universities, though they take a long time. The University of Nairobi at least started producing pharmacoepidemiologists and pharmacovigilance at master's level. Some are now doing their PhDs in the University of Karolinska in Sweden. And when they come back, they are real scientists who manage pharmacovigilance issues. They look at a molecule and say, the likelihood of this causing this side effect is high. In people from a certain region, maybe this region has sickle cell anemia is predominant, and they'll say this molecule is not good for those people. So at the end, the outcomes of looking at our people then becomes better. Instead of chancing, we have people who can say, no, don't even start it, because it will cause this problem in a certain region. Yeah.
Yeah, thank you, Dr. Sioi. As we wrap up with this group, because we want to get some quick views on from the local manufacturers as well as those in the supply chain, I want just to give you, 30 seconds, parting shot. Is there a product you would have wished to see as you walked around? And, how do we get, that product maybe in the next expo, produced by one of our own? Yeah. Or what is that one thing that we need to do to really move this agenda forward from where you sit? Thanks.
Yes, moderator, one thing that I would like us to do is to work together. You see, and we must work together. There's no way out. And with KEMRI, what we are doing, we are opening a new avenue of working together with the industry. And this time we are signing some MOUs with industry. We want to work together with Dr. Sioi, Pharmacy and Policy on Board. We have signed some MOU with Kenya Biovacs, and that is it. We must work together, you see, as a team to develop these products. Thank you.
Thank you. Collaboration. Dr. Sarah?
Thank you very much. For me, I think we just want to assure the public that we are the gatekeepers. We have the national mandate to protect the public from substandard products and falsified, actually, products. So the idea is to encourage the local manufacturers to uphold quality, so that when I tell the public that this product is of good quality, then I can say that with confidence if I've tested it. We've seen a lot of polypharmacy, so just want to encourage the local manufacturers to formulate products that can just be taken as one tablet so that our patients can have better compliance. Thank you very much.
Wow, great. Uphold quality, I'm sure they are hearing. And I love the idea of exploring more, answers to polypharmacy. Dr. Sioi?
I think for me, for the local industries, we are at 28%. Can we go to 100 or 120 so that we are net exporters and not importers? You can see the market is there, but you cannot satisfy. So if there is anything that we can do as government and regulators, let's dialogue and we make sure we have security of health products in this country and some to give other people. Thank you.
Yeah, thank you. Dr. Sioi says the market is there. I think we'll advance that conversation with them. And I love the idea of, actually thinking beyond the borders. Milka, you've mentioned that you have some provision for procurement of, is it kits from local manufacturers? Do we see that happening? Maybe as you do your parting shot, you could tell us what do they need to do to get that money into their pockets and Kenyan pockets. Thanks.
Thank you so much. I think one of the key things, first and foremost, is for the regulator, and we are really looking forward to celebrating PPP achieving majority level 3. That will really be, one of the key things, and we are really looking forward to that happening, and we hope that the timelines that are already there will be met by next year. The second one, of course, is what has already been made. That's the quality, ensuring that these products are quality and are really regulated by a pharmacy and poison sport that has met majority level 3. And I think the other one is, of course, what that Biofax talked about in terms of meeting WHO pre-qualification. I know for sure it's a journey, but I think there are manufacturers here that have already gone through that journey, and I think that will be important. Even for the products that are being produced here to access other markets. So I think we are here to support, provide technical support in ensuring that they have access to what it means to take their products to get that pre-qualification.
Yeah, thank you. And Dr. Luciola, Senegal is also having their own biovacs. South Africa has their own biovacs. What do we do to make sure that we are ahead in terms of capturing the market, the regional markets, as you give your parting shot?
Thank you for your question. And maybe for us, is to look at it in a different way. It's not in terms of competing, but complementing. And at the moment, we in Africa, amongst us who are vaccines manufacturers in Africa, we're already talking together on how to shape the African continent market for vaccines. So Senegal could be an expert in, for example, yellow fever vaccine. South Africa could be an expert in a different category of vaccines. We could be experts in a different category of vaccines. When we all come together, we complement each other. And that is actually the conversation that we're having at the Africa CDC, Africa Union level, how to complement each other. I think for me, the parting shot, or what I would have liked to see, and maybe we can have it next time, is to involve the universities, the students, so that they can also see what local manufacturing or what pharmaceutical manufacturing is all about. I think we, as local manufacturers, I think we've really focused on the end product, but we also have to think about workforce development. We have to think about the students in university who want to come and work in our institutions to gain that knowledge so that they can apply it in the future. I think involving students is really critical. Thank you.
Great. That's quite a very good point, and I think I saw a couple of universities here, so it's exciting that they're also part of the ecosystem. As we wrap up, I just want to highlight that we are going to have another set of panelists so that we advance the conversation now to see the market side, the procurement side, and the distribution. So I want to request that we give them an applause as they walk back to their seat and we get the next panel before questions and answers. Yeah, so thank you very much. So I want to invite the next group that will help us to advance this conversation, but now from the, where the rubber meets the road, the ones who are manufacturing and their representatives, as well as the buyers. So I want to invite Nihal, Dr. Nihal. A clap for him as he comes to the podium. Dr. Rohin. You can take the seat on the extreme left. Welcome, Dr. Rohin, with a clap. Vinod. Dr. Vinod, just come over. Is Dr. Mulwa around? I think I'd seen Dr. Mulwa. Dr. Mulwa, where are you? Dr. Mulwa and Dr. Nandama, if he's around, I am expecting them here. Dr. Otundo, where is he? A clap for Dr. Otundo. Why is Dr. Mulo? I think I'm expecting Dr. Mulo, Dr. Nandama. We want them also to chime in into the supply chain discussion. You can take this seat. Yeah? Okay, great. Dr. Tim Theuri. Dr. Tim Theuri is a representative or heads the KHF Secretariat, so come over. And Dr. Mulwa, if you happen just to see him, just tell him to join us. So, welcome. I think we will use the same format, just maybe a quick intro from Dr. Nihal. I'll just give you a few seconds to say who you are and, and the governance organ for the local manufacturers that you represent.
Yes, good afternoon, everybody. My name is Nihal Shah. I'm the CEO of Biode Laboratories, and I'm here in my capacity as the Vice Chairman of the Federation of Kenyan Pharmaceutical Manufacturers, and we represent about 22 members of pharmaceutical manufacturers here, most of whom who are exhibiting here today.
Dr. Rohin.
Thank you, Dr. Nyingi. I'm the CEO of Regal Pharmaceuticals, a local pharmaceutical manufacturer, and I'm also the chair of the pharmaceutical sector at the Kenya Association of Manufacturers. Kenya Association of Manufacturers is the main body which overlooks the local manufacturing industry, and we have 14 sectors in that in the association. Thank you.
Vinod.
Good afternoon, everyone. Vinod Guptan is my name. I'm the CEO at Medsos Group, which is a digital pharmaceutical supply chain innovator disruptor in this market. I'm one of the board directors of Kenya Healthcare Federation, and I also chair the supply chain committee of Kenya Healthcare Federation. And Kenya Healthcare Federation is the umbrella body encompassing of over 200 plus members of the entire healthcare sector, from the provider to the manufacturer to the patients and to the payers as well. And Kenya Healthcare Federation is the health sector board of KEPSA.
Dr. Otundo.
I'm Dr. Otundo, the CEO of Springs Pharmaceuticals. I'm a chairman for the Kelo Pharma. That's a small group of medium to small manufacturers who have certain special needs.
Dr. Tim.
Good afternoon, everyone. Dr. Tim Theuri, the CEO of Kenya Healthcare Federation. Dr. Vinod has said what we do. Elsewhere, I sit as a board member of one of the regulators, that's Kenya Medical Practitioners and Dentists Council, and the president of Kenya Dental Association as well. Thank you.
Yeah, thank you. So we've had the perspectives of the regulators, those who are in the innovation space, some perspectives from those who are in the development space, and they've said that the market is there. From where they sit, there's a market. There seems to be some money for products from some development partners. There also seems to be, all the necessary infrastructure for purposes of testing products, and where there are gaps is being addressed. So I want us to speak to, why are we not then meeting the target that Dr. Menge was sharing in terms of the product range? What is the main issue in the landscape, Dr. Nihal? If we begin with you.
Yeah. First of all, let me say thank you to this team of the Ministry of Health, Department or Directorate of HPT. We've set this together. And in doing so, they've actually made my work a little difficult, because when we come here in such forums, we're usually armed and prepared with all the statistics. Dr. Menge has done all the numbers for me. So I don't know what, so you see, I don't have something to say. So it's really easier, so it's really making my job a little harder, because you always come combative. But if you look on the market side and what's been happening, and I want to focus on this 30-70 number. This number has been around for at least the last 50 years. Everybody keeps saying 30-70. But also at the same time, the local manufacturers are growing at around 12%, 10 to 12% compounded growth rate every year. So some of these numbers I think we have to re-examine, because we believe when it comes to volumes, We believe that we are probably supplying 60 to 70% of the volume of the market, but because local manufacturers are affordable, cheap, the values compared to the imported products are perhaps lower. So we might sell 1 million tablets for 1 million shillings, whereas if you look at maybe 1 million tablets from Novartis or Bayer or some of the big pharma, there might be 100 million, right? So just to put that into perspective, the first thing. Second thing, over the years as FKPM, we've been lobbying the government for better trading business. And sometime in the 90s, I think the government and maybe the market decided it's to take the easier route of importing. Before that, we had a very robust industrial policy. And you can see that from the 20% GDP contribution to 8% now. And if you come back to the pharma space, what we've seen is unfettered access to generic medicines, almost 1,000 factories registered in Kenya, and all the essential products, which makes it very difficult for local manufacturers to fight against the imports, not just on pricing, but just sheer volume that comes in. However, we're still doing it, we're still growing, and we're still managing to do this because all the local manufacturers, most of them, end of the day, the founders are entrepreneurs, they're innovators, they're problem solvers, and access to finance, we're solving all these problems, we're solving HR problems while we're doing this. And this is perhaps, while we've been solving internal problems, we are now able to develop the markets because we have, again, the market acceptance, going to market, all those are big challenges, simply. On another, if you look at also some of the other programs like the HIV, TB, malaria program, there is no incentive for local manufacturers to manufacture any of these big three problems, simply because Global Fund comes in, has given the Kenya government and the rest of the African countries, we will provide these medicines to you on a WHO pre-qualification. That means that the tender is open worldwide, and most of the investors here would say, well, do I spend millions of dollars and there's no guarantee of the money, no guarantee of sales, or do we just go with, let's say, whatever we have, which is some of the over-the-counter categories, some of the other essential drugs which are required. Within that, there's some commendable steps made by KEMSA, I must say. So since 2014, the first framework contract from KEMSA which came out restricted about 6 or 10 molecules to local manufacturers. Today, they've opened up 60 molecules for us. That now gives us incentives to say, hang on, these are the molecules we're not producing of this 60. Let's go produce it. Let's go happen. So you see, there was also a market barrier if you look at the KEMSA, which is the largest producer. So these are some of the barriers which we've had. But at the same time, the market is growing. So you have to wonder what's going on. There's a lot more growth to be had.
Good. If the market is growing, and that definitely speaks to the potential of the market. Dr. Rohin,
yes.
I know you've been also representing, the manufacturers in the Kenya Association of Manufacturers, where perhaps you can say the pieces come together, not just from the health, but also the other sectors, including trade. If the market is growing, then why are we not growing exponentially? If why is our growth still? Because the 10 to 12% that I think Dr. Nihal has talked about has been in the records for a while. So if the potential is that big, and the need is definitely there, so what's a big, why are we not moving as fast? And perhaps as you speak to that are we growing the market maybe just for certain products, any potential, maybe moving towards the active pharmaceutical ingredients? You can speak to that.
Wow, that's very many questions at one go. Why are we not growing to the potential that we have? Straightforward answer, there's a lot of imports coming in. And why should we import products which are being manufactured by all these manufacturers? I mean, even I'm impressed with what is here. This has been a long time coming. So I think one of the first things we should be doing is, if we're manufacturing products locally, whether it be essential drugs, whether it be something that is in the pharmacy space, whether it's in the kiosk space, why do we need to import them? We're manufacturing them locally. Let's stop the importation, number one. Number two, we always talk about cost, price, quality, availability. They go hand in hand. You know, it's a well-known fact that you can go to your own kitchen and see what is being manufactured or what is being cooked instead of going to a restaurant and seeing what's being done. So let's have the regulators see what's being done within Kenya so they can see what's actually being manufactured. The other thing, which is really good, which Dr. COA mentioned, and where Kenya is going towards ML3. When we get to ML3, anything that the regulator, any product that the regulator authorizes, does it really need WHO PQ? Because as Dr. COA said, that quality is guaranteed. The minute a product is manufactured locally and it's approved by the local authority, the regulator, it is at the appropriate quality. I'm not saying that the quality levels are not there, they're there.
Yeah.
And thirdly, going to manufacture of the actives. I think we can, but it's too soon. We need to get our finished products to have a sufficient mass before we even start looking at the active. As of now, you just said, Dr. Menge said, we're not manufacturing, we're only manufacturing, I think, about 20% of the essential drugs, but I'd say we're still also manufacturing the pharmacy lines, the general sales products. So let us get to a stage where we can manufacture everything that is required locally, right? Before we start thinking of active pharmaceutical ingredients. And it's also the same thing that was done in Bangladesh. They did not start manufacturing their active ingredients until they were self-sufficient in the finished products. Same with India. Thank you.
Yeah, thank you. I want to turn to Dr. Vimal and Dr. Theuri, because they sit in the space of, the federation where you bring together the private sector players. You've had definitely that, the potential is there and the growth is there. We've recently had also, a commitment and a significant pronouncement from the president and the cabinet, committing to, to undertake, to move preferential procurement to the next level. And you've had them speaking to, that space. So with, these initiatives, from where you sit, do you see, a quick take up of the opportunities? Because even in the past, we've also had preferential procurement still happening. Do you see that happening soon? And if not, what needs to be done? So this opportunity for preferential procurement, because, and I'm asking you and Tim, because you sit in a space where all the private players are, and definitely, some of these, significant and good policies, affect all players. So what do you see as an opportunity there? Thanks.
Thank you, Sam. So first of all, I want to remove the fear. People have all gone silent. Dr. Tom Menge said that it's 15% of the essential medical drug list that the local manufacturers are manufacturing. Remember, it's the essential medical drug list, 1,000+ product, but they're also manufacturing quite a few of other products that are pharmacy related, that are treatment related, that are catering to different segments, and also for general health and general well-being of the consumers, not only the patient. So it's not that it's a scary situation. We have strength in local manufacturing. We have strength and capabilities that are existing in the local manufacturers that are catering to many of the products that are being supplied in the pharmacy. So one, remove the fear that we don't have products. In the space of supply chain availability or getting to know, I think we should start first from the essential medical drug list of which are those products that the local manufacturers can have capacity to manufacture, and what are the pain points of them not being able to manufacture and service the market, and hence products are getting imported from outside. but also looking at how we can get, well, of course, now with PPB moving to ML3, we should have avenues and we should have negotiations, intergovernment maybe, donor-funded maybe, development partners maybe coming together and having or assisting conversations of tech transfer. Why should products be manufactured in different parts of different continent and coming to Africa? Why can't it be manufactured in Africa for Africa is what we should look at. Why can't it be manufactured in Kenya for Kenya and beyond Kenya as well? Because we have the strength in being a good local manufacturer in the entire sub-Saharan Africa. It's not only East Africa, but in the entire sub-Saharan Africa. A lot of our Kenyan manufactured products moves right up to Malawi, Zambia. I think we are not able to go down south because the cost of transportation and logistics is what is hampering moving the products further down south into the Southern African market as well. So if we merge products that Med supplies, that KEMSA supplies into the market, and you find out that it's not 15%, it's more than 35, maybe 42%, if we take an average of all the products that these two entities are supplying in the market, are local manufactured products. So it should give us a good feel that we have avenues for further growth. We have avenues where the 1 billion population that Dr. Sioi spoke about, 1 billion plus population that we could cater for. So how do we build capacity? How do we ensure that there is visibility? And how do we ensure that we open up these markets for our local manufacturers, what we should look at?
Yeah, Dr. Tim.
Mine is to say that we need a value chain-based approach as we are bolstering local manufacturing so that the entire value chain has visibility of what is being manufactured, what is being produced, and what is the availability like. One of the groups that we must target are healthcare workers, just to let them know what is happening in the local manufacturing space, so that we inculcate the buy Kenya, build Kenya. Because without that, we will not have drivers for demand, first locally before we even go regionally, and subsequently internationally. The second thing is data. The sector needs a lot of data that is being produced by the value chain. And I'm happy to hear the conversation of the digital superhighway that the Ministry of Health has really been pushing. And once we contribute to that data, and I'd like to urge everyone in the value chain to contribute to this data, because it is not only useful to yourself, but to everyone else. And when everyone else is able to have their business move to the next step, so will you. So we need that data for them to know what the trends are like. And thirdly, we are having an epidemiological shift in the country in terms of the disease profile, moving from communicable diseases to non-communicable diseases. So how are we becoming industry ready as a manufacturing segment for us to move to that? You asked what KHF is doing. We aggregate business member organizations, and these are the conversations we have with them. We are part of a consortium funded by USAID on local manufacturing, and as the conversation advances, we may house a secretariat that will bring to life the thoughts of that project. And now with that, we hope to bring better coordination into the segment so that we are able to spur the growth that we are themed on in this expo.
Yeah, thank you. I want to turn to Dr. Otundo. You have lots of experience both in the distribution space as well as manufacturing now. In the 20 years or so ago, there were a lot of stories about mergers, acquisitions, of pharmaceutical companies. I think we don't hear much of that. In our landscape, we also hear that our capacity is underutilized in terms of production. So with this market that is already there now, with a preferential procurement, commitment, do you see, the local manufacturers now, moving as quickly, and do we need maybe certain shifts to capture the market, both locally and regionally? Speaking from where, or is there another critical barrier? Thanks.
Okay, thank you. Yes, of course, I've been in industry for the last 33 years. what I can say, I had experience from the retail to distribution and now manufacturing. I would say I'm even seeing some of my previous suppliers, they are moving on to the third generation, which really is very commendable that they have a lot of faith in what they've been doing over the years in the local manufacturing scene now. The capacities are there. We are picking on one sector when we say that KEMSA, once they make it local manufacturing, which I say is very commendable from the government, for us to be able to have certain products which are reserved for us. We really need to have a different conversation what is in the private sector. Some of my colleagues have actually talked about the same. We need to look at how we can have all these locally manufactured products getting to the end chain. It's very important for us as manufacturers. Manufacturers put in a lot of money. We may not do so much at the level of R&D, but at the end tail, it's very expensive because all the retail pharmacies you see out there, all the distributors, all the clinics you may find, depending on the hospitals, are actually funded by us, 100%. With no, even what I may say, securities. It's the nature of the industry. What I will ask is that, what different way can we have this conversation so that this impact is felt? There's nothing new for Kenya to fight that what you already have being manufactured locally is given preference. I think the case of Bangladesh has been mentioned. We brought up this issue before in a conversation on Monday with the PS, and I do think that many of them, the faith they have had in the industry for several years, if they need to increase the capacities, they will. If they need to diversify to get newer molecules coming on board, they will. We started off with the people who are on the cutting edge. Of course, the guys at Kemri. We have the people who are here before us. I'm not so sure how I want to go to that level in terms of investment if I don't have a certain level of, some sort of protection. It has to be that. Really, we just have to agree that's the way to be. Unless if it's a crime, then obviously we don't want to get into crime. But I do think we have to be brave. We have to be active. We can't be passive in something which is supporting so many families all the way across the whole country. That's what I would say about our capacities.
Yeah, thank you. You've touched a bit on shaping the direction that the market takes, and I want to turn to Vinod. We would have loved to hear one or two things from KEMSA and perhaps maybe the perspectives of the faith-based ones. But from the private sector, beyond KEMSA and MEDS, because preferential procurement may apply to government, but there is still also opportunity from the private sector. Do we need certain, or what are you observing, or do we need certain shifts, in the market for purposes of shaping what our producers do for the future, and what would be that maybe big shift? Thanks.
It's a good question, but a tricky one also. So looking at the private sector, do we have the strength to provide access to those products that the patients need in the last mile? Yes is the answer. Do we have the strength of manufacturing all the products that the market needs? No is the answer. Do we have the strength of ensuring that the patients or the consumers get good quality product? Yes is the answer. Having asked these questions and answered myself, we need to look at what is it that the market is not ready to take in terms of getting guarantees that our locally manufactured product is as efficient, as quality conscious, consciously manufactured, is the perceived value of the Kenyan manufactured product is much better than those ones imported from wherever. I don't want to name the countries, but from wherever. So if you even ask the patient, I have this product, or if while dispensing from the pharmacy, if the pharmacy says I have this product and I have this one is costing this much, and if the price difference is not too high, the patient chooses the one that is imported. Why so? Should be the question. How can we now create, let's say, just going by example, how can we create that green lift symbol that we had for the AM/FM AL product that went throughout the country and the others were not moving? How can we create the Kenyan manufactured products to be equally taken in as a good quality product throughout the patient cycle in the entire supply chain? Even that includes all the distributors or wholesalers that form the middle chain suppliers in the ecosystem. So how do we create that value for the Kenyan manufactured product is the question we should be asking, and hence find avenues of our product competing equally or better than the imported products in the locally manufactured, in the local market.
Interesting. Is there potential for mechanisms for aggregating demand and then maybe going to the local manufacturers at that level? Maybe you could speak to that.
Yeah, so digitization is one way of looking at it, and many are talking about AI, artificial intelligence. We are not talking of our own intelligence. We are moving to the next level. So let's talk of our own intelligence. So we have database, but the unfortunate part is each one has for his or her own. Now, when that happens, you are competing with yourselves, and you're not competing as a country within ourselves, by ourselves. So this is where we are lacking. So this data of that product being manufactured in this country for a specific ailment, maybe let's even take a molecule. Every manufacturer in this country has, but they will never share it with the other one. Now this is where we lack. So can we have a central repository of not brands, but molecules that are moving in which part of the country at what time of the year, so that the manufacturers focus on that pertaining disease segment and ensure that they are manufacturing. Maybe let's not even get there. If we look at data and data analytics and say that we have, out of the 40, we have 37 that are manufacturing paracetamol. We are competing with ourselves and then blaming the outsiders for coming and selling in our country. So how can we build capacities within the local manufacturers to have specific products that they share or they manufacture for each other? Number one, is it possible? Maybe it's a conversation that we should have. Number two, how can we use the existing capacities that are not fully utilized, and hence the ROAs are better for the local manufacturers by providing them data of the molecules that are moving in the country that they could manufacture themselves. And I also already mentioned that PPP moving to ML3, we should now start having conversations in trying to have partnerships or collaborative approaches for tech transfers and product being manufactured in the country. I need to add one more point. KHF becomes a very neutral platform to have these kind of engagements and conversations. So we should start looking at how KHF, the consortium that we are now forming or putting in place, becomes the talker, or becomes the one that each one is coming together with a neutral opinion, neutral platform for each one to start benefiting out of the discussions.
Yeah, thank you. Those very good insights, and I'm sure Dr. Sioi is also keenly listening to those contributions. I want to turn to Dr. Nihal and then Rohin and Otundo, because you're from the industry. Of course, most recently we've had quite some, advancement in terms of the healthcare financing landscape, in terms of moving towards creating clear funds for purposes of insurance. Which perhaps might have some implications. Are we readying ourselves as local producers to take advantage of the financing that will come out of those? And maybe what would you share?
It is. When it comes to financing, it's a very loaded question, because if you see there's about 30-40 manufacturers, most of them have already put their own, the owner's own funds into it. They've borrowed from the banks and paid back. And I think the question here has always been one of return of investment, which is what Dr. Otundo alluded to. What's happening? Down the line, pharmacies, wholesalers ask for 90-day credits. There's a whole system whereby it's taken for granted the manufacturers can afford not to be paid, actually. So that has to be changed, either through regulation or something, because if we get paid on time, then we are already financed. A lot of our finance, a lot of our things is sitting with our customers, number one. So, and that's the same thing that happens in KEMSA. For example, right now, over 200 days, manufacturers have not been paid. So it's great that their operations have done so much work in there. We were able to supply to them. But at a certain point, when KEMSA does not pay on time, our operations start grinding to a halt because the numbers are big, and we know it's big. And this is also one of the barriers in the first conversation, that why aren't we growing so much? A lot of the manufacturers might decide we do not want to supply to KEMSA because of this issue. Maybe we do not want to have this for certain essential molecules because because competition has driven down the price, but we're not getting paid for it. So that's number one. So on the other, so how does the other finance mechanisms comes to us? If you even look at the current NHIF financing, most of my employees, I'll just give my example because I never use NHIF, but when the NHIF goes, they come and tell me, can we have 1,000, 2,000 shillings for this? Oh, but NHIF covers you. No, it doesn't. They don't get the money down to the ground, to the ordinary Vananchi, right? So what is happening there? So you can come up with all innovative forms, but the basics of finance, basics of accounting is very simple. We must have payment structures in place, even if it has to be regulated, right? We have, so this is again through private market, through KEMSA. The banks, I've been talking to the banks for the last 10 years. What can you do for us? African Development Bank came in, and they're talking of $50 million, $100 million worth of investments, right? This is massive, because when we don't have the guaranteed sales, we cannot go and invest $100 million or $50 million or $20 million. So we're very, very cautious with our investments, which feeds into the 30-70. So the question here then becomes, what do we do to blow that open? Let's get some protection, right, into local manufacturing. Now, what kind of protection a few years ago was a very dirty word. When we spoke about it at some of the international conferences, no, WTO, you cannot talk about protection. Today, look at the US, look at India, look at Bangladesh, right? There is protection, and we must be protected. And in our own FKPM strategy, we have very simple outlines, some very simple things which the government can do without affecting any bilateral treaties, without affecting even imports, so there's no shortage of that, but which over 1 or 2 years, if implemented, will certainly start growing the industry at a rate that's never seen before.
Yeah, thank you. Dr. Rohin, as you give your parting shot, how are you readying yourself to take advantage of the, all these financing initiatives? Thanks.
You've seen the current headlines where the interest rates are at 16%. And they'll probably go up. So I think we need to really rethink how you will finance the local manufacturers. That's at the Kenya shilling. If they want financing in dollars, you're looking at 10, 11%. So to grow, how are they going to do it? But something Nihal mentioned about payments from KEMSA, where he mentioned 200 days. I think we need to take note that we have similar entities within the region. And some of the entities within the region, when I say the region is EAC, they pay within 60 days if you supply to them. Now, if you look at within the local space, if we get paid at 200 days, where is that finance going? Where is the cost? And then we have to tender at the lowest price that we can, but the finance cost increases the cost as it is. The other thing is, again, investments within the country. The cost of investment of a facility, the pharma space is very specialized. We have to have machinery, we have to have laboratory equipment, we have to have specific ventilation systems, we have to have specific paneling. Now, the government has done well over the last 2-3 years, where they have given exemptions on equipment, ventilation equipment, IDF, RDL on materials and stuff. However, there is still, when you put up a facility in Kenya, vis-a-vis if you put up a facility in Uganda or the region, there's one monster in, because the product is currently VAT exempt, the finished product is VAT exempt, so any VAT that you pay you can't claim it back. So that goes in as a cost towards the investment. So your cost has gone up. Pharmaceutical facilities, as I said, need laboratory equipment where you pay VAT. So again, you can't claim that back. So that cost goes up. The paneling, we've got paneling. When I talk about paneling, most of you must have seen the panels that are done at JKIA, Terminal 2, where they've set that up. That's the sort of paneling. If you import the paneling, you pay 35% duty. Not the same within the region. So even if you want to set up a facility, you're already 30 to 40% expensive compared to the region. The other thing is, we talk about SEZs. It's a good thing for a new investor or somebody to put up a new facility in an SEZ. What happens to the people or the local manufacturers who are already here who want to put up a new facility but it's not in the SEZ? What happens to them? They're competing in the same space. So I think we need to internalize and see where we want to go. And where we want to go is we want to reduce the reliance on importation and have self-sufficiency, which will also lead to social security, which will also grow the ancillary industries which are supplying the local manufacturers. So I think the parting shot is let us reduce the dependency or stop the dependency on imports that are manufactured locally, whether it be essential drugs, prescription-only items, pharmacy lines, and general sales products. Thank you.
Yeah, thank you. Let us stop the dependency. That's a good point. And now to turn to Dr. Otundo as he gives his parting shot. Even as we stop the dependency, will we then give preference and then have more expensive products simply because there's a preference? How do we balance that with, of course, the need to make sure the products are affordable with your rich experience?
Of course, the products will be made to be more affordable if you help the local manufacturers to increase their capacities. Because obviously, economies of scale change when somebody produces 10,000 bottles compared to 1,000. So it's as I will agree with what my colleagues again have said, it's to avoid dependence. I think we're just forgetting just 2-3 years ago, COVID, and the devastating effect it had worldwide, and what if you wanted to see which most selfish country in the world, you could easily pick. So we must build the capacities. We must be assisted to have faith that the market can be cut out for us, because banks are always there. I know it's a big challenge, the figures they have raised. We need to look at the GDP that manufacturing is about 7.8 now. From last year, I think it was 7.4. We stop it going down further. Certain sacrifices have to be made. That would be my contribution.
Yeah, thank you. Dr. Vinod and Dr. Theuri, I mean, you've had, the market side. We've heard about, of course, how we are addressing the capacity issue. As you give your parting shot, I want you to speak to the issue of the evidence that you have now that you are in the space where you deal with various players. So do we have sufficient data to help these local producers make the right decisions, even in terms of the products that they should target, and the like?
Yeah. Going a few years back, we had probably extrapolated data from various entities that do a few random sampling from the market. But today, we have, and proudly we can say we have quite a few institutions that give you real-time data, and it's live real-time data. So data speaks for itself, and it can help the local manufacturers strategize on the product, the disease patterns, the segments of, or even more so, specific areas of where the disease prevalence is there, and hence cater for those markets more with more quantities of the products to be offered to those areas in the country, and hence have efficiencies built up in the entire ecosystem. So yes, data speaks for itself. How can we collaborate? How can we have better partnership discussions? How can we help each other to grow our own local manufacturers in Kenya is the conversations we should have. And we have enough data to speak on this, including financing options of what my co-panelists spoke about. So there is enough evidence and enough data of available options. How ready are we to talk about is what we need to look at, coming together, not as single entities, coming together.
Thank you. So, Dr. Theuri, how do we bring all these people together with all the issues that you've had? I know you've made significant attempts, but perhaps what do we need to do better as you give your parting shot in terms of bringing all these critical players in the ecosystem so that we, shift, faster, we move faster, we address the barriers that they are mentioning. If the market is assured, we secure it, as you give your parting shot.
I think two things come to my mind, and one is we must like ourselves a little better as Kenyans. And by that I mean we must promote what is locally produced and ingrown. The same way in agriculture we give preference to what we produce locally, the same should be extended to pharmaceutical local manufacturing. What I have seen here today, and anyone who's gone through the exhibition space, is world class by any standard. Yeah, there's no difference between what is coming from outside and what we have here actually, and we must drill that into our thoughts and into our way of life. That's the first thing that we must do. The second thing is we must have a conversation with the financial services sector so that the capital that comes into the local manufacturing pharmaceutical space behaves a little different from what they're used to in terms of cost and in terms of tenure, so that we are able to bring much more growth to the sector. And then thirdly, we must agree to be brought together as the entire value chain, so that as we are having those conversations, they will initially be difficult, yes, but we must have them, so that we say this is where we are going. Even if as a company you may not be aligned to that, we give you some time to align to that and help you on your way there, so that at the end of it all there's space for everyone, and we grow this sector, because without it, it is impossible to bring affordable healthcare to Kenyans. And that is why commodity security is one of the 4 pillars that is buttressing our third attempt at UHC, and we must take it seriously. Thank you.
Yeah, thank you so much. With that, I want to really thank the panelists as we get maybe to open up for a few questions before we wrap up. You've had the critical messages that this panelists have echoed, and I think which were also highlighted by the area group. We need to love ourselves more, as citizens of Kenya. You had quality mentioned, I think, 1,000 times now. So quality. So not just loving ourselves and using our products, but also the producers must ensure that the quality matches, the standards that have been set. And of course, the idea of rethinking the structuring of financing, perhaps also that's another area that we need to innovate. So as we move to the next session, maybe just a brief session on questions and answers, I want to invite you to give a loud applause to this group of panelists who have given us industrial insights. Thanks. Yeah. Good. So I think we can get back to our seats. Dr. Menge, do we have time for questions?
Thank you very much, the panelists. You may have your seats. And I just want to open up the rest of the discussion so that we can be able to interact with the various exhibitors as we hang around for further direction. Thank you very much. And thank you, participants, for being with us. And for the other questions that you may have, I believe we've seen the panelists, and we can be able to interact with them during this break we shall have. So kindly make your way to the exhibitions, familiarize yourself with them as we continue with the event today. Thank you so much, and let's enjoy a break before we come back. Thank you.
Well, good afternoon, Troy, and I must say off cuff that I'm jealous that you are back there in studio where it is cool. We are currently outside the Kenyatta International Convention Center, and well, we needed to get a shade because it's quite hot. But now, why have you been here since morning is that we are having a two-day forum that is bringing together local manufacturers within the health sector value chain, drawn from Kenya as well as the larger East African community. And we just ended our first panel, and the panel there, the conversation was about how do we lower the cost of health services and products. It has been said by some of the panelists that a majority of Kenyans, especially when they're dealing with major health situations, they prefer to seek services from abroad. Why? The issue is the high cost of services. And today the question is, how do we lower the cost of health services? Some of the suggestions that have been given was to look into the taxation regime that we're currently operating in, as well as create a level playing field for local manufacturers against high imports, as well as create markets and demand for health services within the local area. This is a panel that has just taken a break. We are expecting President William Ruto to also grace this particular occasion. Remember, the government has really been focusing on pushing the universal health care agenda and program, so to speak. So those who are here, stakeholders drawn from across the health sector value chain, want those key issues addressed, the cost of production. And as they took their first break, what they said is that if the cost of production actually comes down, then they'll be able to continue rendering services at an affordable rate. Another issue that has come up at Troy is the issue of pending bills, especially those who have been doing business with government are saying that they are yet to be paid for their products and services months on end, and this is threatening to cripple their businesses. Well, we are not done here. This is a forum that is going to be running today and tomorrow. We just took a quick break, and I'm sure we're going to be coming back to you, Troy, once the chief guest, who is President William Ruto, graces this particular occasion. For now, that's just a quick summary, and to just recap that is that cost of production is affecting the cost of healthcare services across the country and across the region. And if Kenya should continue being a medical hub, then something has to be done. That is what the panel this morning was discussing, and we're going to be keeping tabs on how the rest of the conversations are going to go, as well as the president's speech once he arrives. Back to you, Troy.
Thank you so much, Regina Manyara. Actually, it's a good initiative that the government has decided to launch the health products and technologies aiming at reducing the cost of health care in the country. The event, as Regina has talked about, will be graced by the head of state a little bit later on. But after this, they will be still having a round table in the afternoon. More of that from Regina a little bit later. My name is Bentro Njue. Thank you indeed so much for joining us. This is KBC Lunchtime News. Brian Muraru will join me in the sign language interpreter. As the sign language interpreter, I'm kindly livestock traders have lamented the high price